Okay, good afternoon. Welcome to the Thurston County Board of Health meeting for Tuesday, August 8th, 2023. It is 4:31 PM. My name is Ty Mentzer, Chair of the Board. Our Vice Chair is excused this afternoon. And Commissioner Edwards, I believe, will be joining us just in a moment. The rest of the board is present. And calling the meeting to order, we have a proposed agenda. Is there a motion?
Mr. Chair, I move the approval of the agenda as posted.
I'll second.
Motion has been made by Board Member Vasquez and seconded to approve the proposed agenda. Any discussion? Call for the vote. All in favor, say aye.
Aye.
Aye. Any opposed? That motion carries and the agenda is approved. Next, we have opportunity for the public to address the Board of Health. And before I go through any guidelines, let me just confirm that we have public comment. I don't have a sign-up sheet. Did anyone who in the boardroom sign up to give public comment?
Is anybody who joined us via Zoom would like to provide public comment? Let me ask again, those who are joining us via Zoom would like to provide public comment this afternoon?
Okay, I'm not gonna go through the guidelines then, because we have no public comment. We do have two proclamations this afternoon. Our first is National Breastfeeding Month proclamation. And I believe we have guests from our Public Health Department, and Gretchen Toller, who is our Division Director, will introduce this proclamation.
Good afternoon, Board of Health members. My name is Gretchen Toller. I'm the Division Director for Community Wellness at Public Health and Social Services. Thank you for recognizing Breastfeeding Awareness Month. Breastfeeding is one of the most powerful ways to promote health and prevent disease in both a child and a parent. It's a public health initiative, which is why I'm so glad we're dedicating more staff time to this important issue, to making sure there's breastfeeding initiation and continuation rates in the community. You remember last winter, you approved the use of foundational public health funds to support a quarter time for one of our nurses to specifically work on breastfeeding efforts. Today, I'm happy to introduce Sheila Waterstrat, who works with Nurse Family Partnership 3/4 time and spends the other quarter time working on breastfeeding. Sheila is a IBCLC, which is an international board certified lactation consultant. And I'm so happy and proud to be able to work alongside her, and I thank her for sharing some information.
Thank you for having me. I'm excited to celebrate World Breastfeeding Week last week and National Breastfeeding Month here in Thurston County. My name is Sheila Waterstrat. I'm an RN IBCLC, and I've had the privilege of working under Maternal Child Health and Nurse Family Partnership for the last year. I'd like to start off by reading a quote from the American Academy of Pediatrics Journal. Breastfeeding and human milk are the normative standards for infant feeding and nutrition. The short and long-term medical and neurodevelopmental advantages of breastfeeding make breastfeeding, or the provision of human milk, a public health imperative. So I think it's pretty common knowledge, even beyond the public health profession, that breastfeeding is good, that there are a lot of healthy choices and benefits. But I think if we actually look at the numbers, it is truly astounding how this one health behavior can affect so many health outcomes in our populations. I'll just give you some of the numbers. If breastfeeding were scaled up to near universal levels, we would save the lives of about 820,000 children globally each year. Babies who are breastfed have a 36% reduction in SIDS. Infants who are exclusively breastfed for more than 6 months are 4 times less likely to get pneumonia than those breastfed less than 6 months. Babies who are exclusively breastfed for at least 3 months have a 30% reduction in type 1 diabetes and a 40% reduction in type 2 diabetes. Preterm infants are 58 to 77% less likely to develop necrotizing enterocolitis when receiving human milk. We know that breastfeeding decreases asthma, ear infections, respiratory infections, and some childhood cancers and obesity. The maternal benefits are astounding as well. Mothers who never breastfed are 32% more likely to develop ovarian cancer. Mothers who are positive for the BRCA1 mutation and breastfeed for at least a year have a 37% lower risk of breast cancer. Mothers who never breastfed are 29% more likely to develop hypertension. And compared with mothers who breastfed all of their children for at least 3 months, those who've never breastfed are 5 times as likely to develop aortic calcification, even adjusting for socioeconomic status, lifestyle, family history, BMI, etc. If 90% of US mothers were able to breastfeed for 1 year after every birth, An estimated 14,000 heart attacks could be prevented each year. 54,000 US women could avoid treatment for hypertension. Reducing this disease burden can save the US billions of dollars annually, preventing more than 4,000 premature maternal deaths and close to 1,000 infant deaths each year. So I could go on, but pretty amazing numbers. So we know the individual health benefits, we know the community benefits. Breastfeeding is environmentally friendly, reduces healthcare costs up to $3 billion a year for mothers and children in the United States, decrease energy demand for production and transportation of formula, and in disaster situations or formula recalls like recently, it offers free and accessible nutrients and infection protection to infants. So the American Academy of Pediatrics recommends exclusive breastfeeding times 6 months and at least a year, and benefits up to at least 2 years. When we look at our national and state data, the CDC shows that most women want to start off breastfeeding. 83% of women start off with any breastfeeding. In Washington state, it's 93.7%. By 6 months, only about 56% nationally receive any breast milk, 68% in Washington. And unfortunately, by 6 months, only 1 in 4 infants is exclusively breastfed, 29.5% in Washington. So what is going on? Why do 60% of mothers stop breastfeeding sooner than they planned? Well, we have some data about the socioeconomic disparities, the racial disparities. These are communities that have been historically marginalized and underserved, and these families face challenges as accessing care and the type of services they need. And unfortunately, these are the infants and mothers that stand to benefit the most from breastfeeding. But unfortunately, formula is the norm. We know that Black and Hispanic children are at significant more risk for ear infections, GI infections, SIDS, and child death due to suboptimal breastfeeding. We know that Black women are 1.4 times at a higher risk for hypertension and type 2 diabetes due to suboptimal breastfeeding compared to white women. So we have this data, and we know we can make some attribution to lower incomes, job insecurity, transportation, earlier return to work, unfriendly work and community policies, increased mental health struggles, and poor social support. So knowing all this, how can we support longer duration of breastfeeding and exclusive breastfeeding practices in our community, particularly our underserved populations? Well, breastfeeding is complex. Of course, there's a lot of factors that affect it. Although individual support is important, we know that breastfeeding should be considered a public health issue, and it requires an investment at the societal level that leads to cultural changes that normalizes breastfeeding in our communities. Fortunately, in our county, we have our nurse home visiting program, Nurse Family Partnership, which shows that 21% more mothers breastfed at 6 months with the Nurse Family Partnership program compared to other low-income groups. Home visitors were in a unique position to meet moms where they're at, to be present during the critical first 2 to 4 weeks of an infant's life, to offer prenatal education, and to offer non-judgmental and culturally appropriate care. We also have been fortunate enough with some of our funding to increase access to breastfeeding support through our drop-in lactation group, which, although only a few months old, has been extremely successful, and plan for a breastfeeding task force to help improve continuity of care between providers and families and the services. So we're also fortunate enough to have some very passionate breastfeeding advocates and resources in our county, South Sound Lactation Network, some private lactation services, La Leche League, and family support services. But more work is needed to increase access to care, expand care services, and offer more education to providers and families as long-term benefit. It is a public health priority to promote, protect, and support chest and breastfeeding equitably. Thank you.
Thank you. Any comments or questions from board members? Commissioner Edwards.
You have all heard me say this for years, but if you didn't lay out a good example of, here we are, kids are 30% of our population, but they're 100% of our future. And if we want to give them a future, let's get it right. And I would like to have that information if I could maybe get somebody to ship it up to me, because I think it's just a very compelling argument that I really think this is probably the most important proclamation that I've ever been involved in, is paying attention to this issue. So thank you all for what you do.
Thank you.
Board Member Vasquez.
I second what Commissioner Edwards said, and I wanted to share how much I appreciate you framing it not just as, you know, providing nourishment to an infant and the medical benefits that that entails, but some of the social supports that, when they are present, allow this to happen. Right, I was fortunate enough to be able to breastfeed both of my kids for, I think, 10 months and then 12 months. Because not only did I get support from a lactation consultant early on and a midwife, but I also had a supportive employer. I had access to paid leave. I had family supports. So I had all of those things wrapped around me that facilitated that beneficial experience for me and my kids. And not everybody has those, and we need to work to make sure that more people do have that kind of support. Thank you.
So this morning I got to see a baby who did have nurse family partnership for their first baby, and then was 4 years later before the second baby, and nursed the first baby for 2 years, and is already nursing successfully. So very important program, see the benefits all day long. And I am finding the state family leave, I think, is helping a bit with the families with disparities, because they're not like immediately thinking about stopping, like they're actually like wanting to nurse longer and they're being more successful. So I'm kind of optimistic that policies like that actually are going to be really good investments.
And I appreciate that comment about the state family leave. I've seen that too with my coworkers. And I'm really glad to see Thurston County put some resources toward specifically lactation consulting. That's great. Your presentation was excellent, and thank you for the focus on maternal health as well as child health, because that's so important, and I'm not sure as many people know about that. Reduction in breast cancer rates, cardiac health. Yeah,
I
thank you.
didn't, so that was what I was gonna comment, is I didn't know that whole aspect of it, so thank you for bringing that to my attention. Commissioner Meehan.
Yeah, no, I just kind of wanted to echo, thank you so much, Sheila, thank you so much, Gretchen. I think every time, we see these proposals and actually, I had a lactation consultant too as a first-time mother. It's not as simple as it's made to seem, and then there's other issues that go into it, and it can be a very stressful time, especially, we were talking earlier, you have all the hormones messing with you, and so having people who know what they're doing and assisting, parents, first-time parents especially, I think it's just so valuable. I appreciate all the information you've relayed of all the benefits. I think it's very important. And also how the social, economic, and racial disparities really play into that as well.
Okay. Are we ready? Yep.
One other thing that I think the community should know, that we made a pretty good run at setting up at the courthouse for mothers and newborn babies. I don't know.
A wellness room?
Yeah, how long ago was that, County Manager? But then we get that going where we had mothers able to bring their,
So we, prior to the pandemic, that will be probably just about 2019, we went through the process of having a pilot
I think
program to
COVID
bring
came
infants
along.
to work. I believe we implemented that in public health. And then blame it on the pandemic. We never really had a follow-up to the success or not of that program. I think it will be a good opportunity to come back, reassess, lessons learned, and perhaps put in front of the board if there's an opportunity to continue with that program.
I would advocate for that.
We might be able to get some money out of that foundational public health money that we're getting. Remember that, Gretchen.
I will.
Are we ready for proclamation? Okay, I'll set it up and maybe we'll just go down this way. So Thurston County Proclamation, Breastfeeding Awareness Month, August 8th, 2023.
Whereas the 2023 National Breastfeeding Month theme is "This is our why," to help shine a light on why breastfeeding support is so important and to center conversations on the babies and families who need support. And
Whereas breastfeeding and chest feeding provides a safe, reliable, and renewable food source, especially critical during natural disasters or emergency situations. And
whereas the act of breastfeeding builds a strong emotional connection between the mother and infant.
And whereas the American Academy of Pediatrics recognizes that breastfeeding or the provision of human milk is a public health imperative.
And whereas breastfeeding can lower maternal risk of heart disease, type 2 diabetes, and certain breast and ovarian cancers, as well as lower an infant's risk of ear infections, asthma, respiratory infections, childhood obesity, type 2 diabetes, eczema, childhood leukemia, or SIDS, sudden infant death syndrome.
And whereas all medical authorities recommend that mothers breastfeed exclusively for 6 months and continue breastfeeding for at least the first year of a child's life, yet breastfeeding rates continue to fall short of the nation's Healthy People's objectives, with 60% of mothers stopping breastfeeding sooner than they had planned.
And whereas employers that provide workplace lactation support experience an impressive return on investment, including lower healthcare costs, absenteeism, and turnover rates, and improved morale, job satisfaction, and productivity.
And whereas there are longstanding policy gaps and underfunding of public health initiatives that address the needs of of lactating parents and the providers that serve them, which unduly impact Black, Indigenous, and people of color BIPOC populations, resulting in reduced breastfeeding rates and an associated increase in risk for a variety of negative health outcomes.
And whereas the goal of our county government is to improve the county's health by working collaboratively to protect, promote, and support breastfeeding.
Now therefore be it resolved, the Board of Health hereby proclaims August 2023 Breastfeeding Awareness Month in Thurston County and encourages all community members to recognize the disparities of child feeding and to promote breastfeeding and services that ensure all pregnant and postpartum women receive equitable care and know the benefits of breastfeeding.
Adopted this 8th day of August, 2023, your Board of Health. And thank you for coming.
You wear your new suit.
Tell us apart.
Oh, terrible.
Yes.
Where is it? Right.
You can send that later.
I'll sign it after we take the picture or something, I guess. Who's gonna take that?
It's just a photo op.
One, two, three.
Thank you.
Thank you very much.
Okay.
Okay, well, we had two that were too important to miss this month, so we're gonna move to item 4, which is a proclamation regarding National Immunization Awareness Month. And we've got more public health of our team to give us an introduction on this one. Good afternoon, Erin.
Thank you. Good afternoon, Board of Health members. My name is Erin Berklid. I am the Disease Control and Prevention Division Director for Public Health. I want to thank the Board of Health for taking the opportunity to proclaim August Immunization Awareness Month in Thurston County, thus recognizing the importance of routine vaccinations for people of all ages. August is a perfect time to ensure that you and your loved ones are up to date on all recommended vaccines. Vaccines play a critical role in avoiding grave and sometimes deadly diseases across one's lifetime. They save millions of lives and are widely recognized as one of the world's most cost-effective, successful health interventions. We would like to welcome Kathy Bay to receive this proclamation. Kathy is the Clinical Quality and School Section Manager for the Office of Immunization Prevention and Community Health for the Washington State Department of Health. We worked in partnership with Kathy's team to deliver flu and COVID-19 vaccines last fall and winter throughout Thurston County. We appreciate our partnership with BoH and the community and look forward to ongoing collaboration as we move forward. I have Wendy Hurst, our immunization coordinator, here to share more about our upcoming back-to-school clinics. Thank you.
Good afternoon. My name is Wendy Hurst, and I am the immunization coordinator for Thurston County Public Health. As Erin said, I worked through COVID with the Thurston County team and the Department of Health team, as well as many of our partners in the area, and it is my pleasure to take on this permanent position of the immunization coordinator. Beginning next week, August 15th, we'll be holding the first of 4 back-to-school vaccine clinics in partnership with the Thurston County Medical Reserve Corps, the North Thurston Public Schools, Tumwater Public School District with Together, and CMAR Community Health Clinics. Our clinics are scheduled on August 15th at North Thurston High School from 4 to 8 p.m., August 17th at Tumwater Middle School, also from 4 to 8 p.m. We'll then be in Yelm at the CMAR Clinic on August 22nd from 3 to 7 p.m. And then we'll be holding a catch-up clinic on October 7th at the CMAR Clinic in Woodland Square in Lacey from 9 a.m. to 1 p.m., and that's a Saturday. All of the clinics that we're presenting are free of charge. Anyone is welcome to come, any child, school-age child. And the August 15th and 17th clinics are no appointment necessary, so they are walk-in clinics. And the CMAR clinics, because they are in a clinic setting, do require an appointment, but you do not have to be a clinic patient to receive the vaccines at CMAR. So we're thrilled to be able to do this. We brought some flyers because we are focusing on equity, vaccine equity throughout our county. We've put our clinics, put our flyers in the top 6 languages in our county, as evidenced by the both of the school districts. Those are the languages that they have.
Highest diffusion.
Thank you, yes. And that's all I have.
Questions for, Wendy, Commissioner Edwards.
How do you address situations where kids end up in a situation maybe where their medical records have been lost or that type of thing? So I don't know, I know you're doing a lot of different types of vaccinations. I don't know which ones, if they double up on them, is it bad, or how do you handle that?
Okay, so we do utilize the Washington immunization system, and so we do have an electronic record with that. And those go back as far as, I think, the late 90s for historical records. And so we are able to access quite a bit with the records that way. We had a situation recently where a family moved here from the Philippines, and because of translation things that we've done, I was able to assist them with translating their health records from Tagalog to English to find out where they were at and what the patients were, the children were going to need for their back to school catch-ups. So that was really, that felt really good because we had just been working on that and it was just awesome. So, and then the doctor's offices also have opportunity to check out the immunization, the IIS system.
I
And
guess
like
I'd
our
like to have your
systems-
parents.
And
know.
our systems upload and then we can download. So
Well,
they're
yeah, but
linked.
that's for
at all
those
times.
people that might be in the system. I'm talking about folks that maybe come here and maybe the parents no longer have custody, cousins, grandparents. I don't know who's got it, but I guess I'd like to make sure we get that message out to those challenged parents maybe that, and I don't want to say, well, come on in, we'll give you the shot anyway. I don't know that answer, but do you folks know that, well, if you don't know, you can do X, Y, Z. Is there a mechanism, a place they can check in so they won't be
There is
hesitant?
guidance related to that. And Of course, Dr. A signs off on those things. We partner with local pediatricians to get that information as well as what comes down off of the Department of Health website and have guidance that is set forth per vaccine based on their recommendations from the manufacturer.
And we can, like figure out what school were they at, what state were they in, who was their, like, who do we think their doctor was? Like, this happens with foster kids too, like where you just have to go on like a little investigation. But a lot of times you can really figure it out.
I was double immunized because when I came from Honduras, a lot of my records didn't make it through. And so I, didn't have the immunization records. And so I had to go through the Department of Health and get my vaccines all over again in order to be able to access school until my records came through. But it was like I doubled up on a lot of them. So I got extra shots I didn't want. So I'm still here and I'm still kicking, so.
Well, I wouldn't want to downplay the importance of vaccinations, but, we should all remember, long before there were vaccinations, mothers were vaccinating their children through breastfeeding.
Exactly.
Way back
We work
when.
hand in
So,
hand.
which one's more important? I don't know, we'll see
We work
here.
hand in hand.
Thank you.
Of course.
And then the one question I had for you is, do you have ways to kind of reinforce that you still need your preventive care? We wanted to connect with the medical home. If you don't have one, here's how you sign up for Apple Health and make sure that they have that blend. Because we are finding with the pandemic, there have been people who haven't come in for 3 or 4 years, and we're finding a bunch of weird things that were missed. And
Yes, and so with that, we are handing, like a list of local pediatricians, a list of local clinics that they can go into, just to make sure that everybody has access equitably across the county, and making sure that, especially when we're out in Yelm or Rochester, things like that, where there's fewer practitioners available too.
My question is, what is kind of the reason for the low rates of immunization in our community that we're seeing? I know COVID had a part to play in it, but as we're getting outside of that.
Well, I think that right now there's a lot that plays into it, and we all know that. We know that COVID had its position in it. I think the other part is that people are thinking a little bit differently, but I think it comes down to education really, and letting people, make up their own mind, but referring them to their practitioners, to their healthcare providers, their primary care physicians, and just getting that information out there and letting them know that there's a lot of misinformation on the internet, but we have good information for you. So, and I try to implement that as often as possible.
do you have a way to see with the people who come and utilize those clinics if they have a medical home? Because what I can't tell is part of this issue access to care? Or is it partly too like that we haven't inactivated the people who've moved and so our data is off? Because like our internal data doesn't match the state data, but
I know that that's something that we've talked about, and that we, just because we are coming out of this and coming into sort of a whole new world now of what people are willing to do. But that's one thing is that people did move, and without any way of letting other people know that they did that, letting their providers know that they have moved and how to catch up and where to find those new providers. And so that's a mechanism that we have talked quite a bit about, and we're looking to implement a system that we can assist those patients, because they don't want to be behind on their vaccinations either. People want to protect their children, so we want to make sure that everybody has access to information, and that we're gathering the information that you all will need as providers.
You, talking the last couple of years about vaccines with COVID so frequently, can you tick through some of the other things that these clinics will cover, types of vaccines?
That will
That
have in the
you'll have
children's
offered at
vaccines.
these back-to-school clinics?
yes.
What are we, what are we talking about?
Yeah.
Okay. Dr. A, put you on the spot.
Oh, yeah,
not a problem. So at these particular clinics,
Yes.
we're going to have, so school-required vaccines, so DTaP, and we'll also have Tdap, so tetanus, diphtheria, pertussis. That's a little bit different depending on age. Hepatitis B, the inactivated poliovirus vaccine, MMR, and varicella, in addition to two recommended vaccines. So HPV and the meningococcal vaccine will also be available at these clinics.
Great, thank you. Anything else for Wendy or the team? All right,
I would love the
Thank you.
flyers that Wendy has. Please.
okay. So I'll introduce the proclamation, Thurston County Proclamation, Immunization Awareness Month.
Whereas Immunization Awareness Month highlights the important role vaccines play in preventing serious and sometimes deadly diseases in people of all ages.
And whereas vaccinations are the main tool for the primary prevention of disease and one of the most cost-effective public health interventions for reducing disease spread, as well as preventing complications and even deaths from vaccine-preventable diseases.
And whereas when people are unvaccinated, outbreaks of diseases like pertussis, whooping cough, and measles can and do return, putting vulnerable people at risk.
And whereas immunizations prevent countless cases of vaccine-preventable disease and save millions of lives, infants, children, adolescents, teens, and adults need different vaccinations depending on their age, location, job, lifestyle, travel schedule, health conditions, or previous vaccinations. And
Whereas increasing vaccination rates improves community protection when a sufficient portion of the community is immune to an infectious disease, thus reducing transmission risk and protecting vulnerable people who are not able to get vaccinated or who do not mount a sufficient immune response to vaccinations.
And whereas vaccines are safe and available and allow our community to stay healthy.
And whereas our county government promotes immunization awareness along with state and national organizations such as the World Health Organization and the Centers for Disease Control and Prevention, and encourages all people to discuss vaccinations with a healthcare provider and to get any needed immunizations.
Now therefore be it resolved, the Thurston County Board of Health hereby proclaims August as Immunization Awareness Month and encourages all community members to recognize the importance of vaccinations for people of all ages in every community across the country, to reflect on the progress of science and medicine in the eradication of contagious disease, and for all residents to do their part to help maintain the health of our community by staying up to date on immunizations.
Adopted this 8th day of August, 2023 by the Board of Health.
Photo op?
don't forget to sign it.
I got it. I got that one. Or is this the one? This is the one, right?
Yeah, that's the one.
Okay. No, no.
There you go.
I don't want them to get Romero and I mixed up.
Yeah, do you have representatives from the healthcare authority at your clinics to connect people with Medicaid services? Yeah, that's a really good idea. I work for the healthcare authority. I can help.
Thank you.
I'll send you an email.
Good job.
Okay, next is item 5, which is a presentation regarding the National Suicide Hotline update. And we have Joe Avalos, guest from Thurston Mason Behavioral Health Administrative Service Organization and the Olympic Health and Recovery Services Chief Officer. And he's going to give us kind of a background because he's been kind of knee deep in.
We're kind of living this for
Yeah.
quite a bit now.
So welcome, Joe.
Thank you. I've got a PowerPoint that I think will help a little bit, because this is kind of a complicated system. I'll try and get through it as easily as I can, but as Commissioner Menser said, I'm Joe Avalos. I'm the Chief Operating Officer for the Thurston Mason Behavioral Health Administrative Service Organization, or BHASO, as we'll call it for short. I also oversee Olympic Health and Recovery Services, and so that is the direct service side of our house of the BHASO. And so I'll talk a little bit about that. Next slide. Oh, perfect. So first, BHASOs are essentially, BHASOs exist in 10 regions, or the state, I should say, is divided into 10 ASO regions. Ours is Thurston Mason. It's been that way, set by the State Healthcare Authority for several years now. And what the ASOs are responsible for is to contract with the Healthcare Authority as well as the 5 managed care organizations or Apple Health organizations in the state, specifically to deliver crisis services for both Medicaid patients and also for those individuals who do not have insurance, or whether they have insurance or not. So it's a publicly funded system completely. The BHASO also provides some other support services, such as voluntary outpatient or housing support services as funding allows. But the primary purpose of the ASO is to provide that crisis system. So next slide. So we do that here locally, primarily through 2 agencies. The first is Olympic Health and Recovery Services, OHRS. That's our direct service arm. We are quasi-governmental, governed by 3 county commissioners, Commissioner Menser, Commissioner Edwards, and then in Mason County, Commissioner Kevin Schutte. And our sole purpose is just to provide an effective, reliable safety net of services. So crisis response, we provide housing support, we provide services in the jail, both Thurston and Mason. It's just about connecting folks to where they need to go, whether that's outpatient, medical, whether, again, housing. It's just about getting them to the next step. And so we've been doing that now since 2017, late 2017. For this presentation, crisis services really are our bread and butter and what we do most. Our team is about 60 people, and they focus on providing the 24/7 regional crisis line. So that's different from 988, and I'll explain how those interplay a little bit later. But the regional crisis line is staffed with clinicians, so trained clinicians in how to respond to all sorts of crisis in behavioral health, whether that's family members calling because their son might be suicidal, or it's a hospital staff calling about people that they have in crisis in the emergency department, or it could be law enforcement saying they need help with somebody in the community who needs crisis response. The 24/7 regional crisis line, our folks answer that call and try to respond with the best response we can, whether that's over the phone or dispatching mobile crisis teams, which is the next thing, 24/7. And those mobile crisis teams consist of a trained clinician or a certified peer. And a peer just means somebody that has lived experience, has had specialized training, and can help engage individuals in the community who are experiencing a crisis. What's unique about OHRS is that the folks that are answering the regional crisis line are also the ones that deploy. And that's unique in this state. Most of the other regional crisis lines in the 10 regions are dedicated crisis line providers. In our region, it's the same folks that answer the call are the same folks that respond in person, so to help with that continuity of care. One of our flagship newer programs that we've been doing at OHRS is our co-responder teams. And that's been a fantastic partnership with many jurisdictions in Thurston and now Mason counties as of this month. We first started with Olympia Police Department. They have their crew team, which is a city-funded crisis team, and we've partnered with them for designated crisis responder services now for a couple of years. And that kind of led to our first co-responder team with the Lacey Police Department, the Lacey Mott team, and that's been fantastic partnership with Chief Almada and his group. That program led to now the Thurston County Sheriff's Office and the co-responder team through their, what they call the Scout team. So again, these are clinicians and peers embedded within each jurisdiction, dispatched by 911 or by dispatch themselves within each jurisdiction to respond to behavioral health crisis, whether they're with law enforcement or in place of law enforcement. The goal is to get people the right response at the right time. I just looked at recent data because I was curious as to how often we were responding with law enforcement and without. And it looks like in our most recent month, we only needed, these co-responder teams needed law enforcement response only 20% of the time, which is fantastic because the whole goal is to give the right response. So by embedding clinicians in directly with these jurisdictions, we're actually reducing police response. If we weren't there, the police would be responding to 100% of those calls that are coming in. So it's been a great partnership. That can't be done, unfortunately, without, well, I'll say that the partnerships and the funding through City of Olympia, City of Lacey, and Thurston Sales Tax are the only way that can make that happen. We do receive state funding and federal funding for the crisis system, but it's finite. It's not enough to really support the entire crisis system without those partnerships. Hopefully that'll change with the new 988 implementation, but we're still not quite there yet. Also, please stop me. I'm talking fast, so please stop me along the way if you have questions. I'm happy to answer them as we go. Finally, the last thing that OHS provides is the designated crisis responders, or the DCRs. And so these are specially trained mental health professionals who evaluate individuals for involuntary commitment. So involuntary commitment is somebody presents as a danger to themselves, a danger to others, or they're gravely disabled as a result of their behavioral health disorder. So we do those services in Thurston, Mason counties, and we also do those in 5 counties outside of the region as well. Next slide. So OHRS handles regional crisis line, the DCRs, and most of the mobile response. But we are very fortunate to contract with Catholic Community Services for a specialized children and youth mobile crisis. That's been a partnership we've been doing now for several years, and it has been fantastic. It's definitely a model that the state is looking at replicating. The CCS provides 24/7 mobile crisis teams. They respond to every child regardless of insurance, Medicaid, non-Medicaid, doesn't matter. They will go to the home, to the community. They will respond typically in less than 2 hours, which is very unique for a crisis response team. And there's got enough of a system and enough funding in place where we can provide up to 77 days of service. In fact, I was talking to Dr. Harvey earlier today. We have mobile crisis response through CCS embedded within South Sound Pediatrics. So that's been a fantastic partnership. And that's part of the CCS mobile crisis response, so we're happy to do that. Family-driven and youth-guided, and again, we couldn't do this without funding, without a variety of fund sources, including Thurston Treatment Sales Tax, so just want to throw that out there. Next slide. Just a brief little snapshot of what some of the numbers look like, because we were very busy. First quarter of this year, the mobile crisis outreach, so in-person services, about 570 per month. And that increased to a little over 700 a month in April through June. We respond to nearly 100% of the services within 24 hours. We'd love to respond faster. I think it's worth noting we're not a first responder system. We respond as fast as we can. Usually, when we get a call, we respond immediately. But if we get 4 or 5 calls in a row, then of course it takes time to respond, and we try and triage those as much as we can. And of course, yes, sir.
Do the majority of those in the past, would they required the police officer to respond, or are some of those with the police officer?
I think it's safe to say that prior to 2018, when we started doing the crisis services the way that we are now, nearly 100% of those were responded by law enforcement. We didn't have as robust a crisis team as we do now. So it's definitely reduced that police response, and of course the co-responder services help as well. The next bullet points there are the Involuntary Treatment Act, or so the involuntary evaluations I mentioned that the DCRs provide. So you can see there, most of the folks that we evaluate, we do not detain. We do not detain to involuntary commitment. It's only about 35 to 37%. That's a good thing. That's a very difficult process to do. It does take away someone's civil rights for 120 hours of a minimum. So we want to do that only when it's really needed. Most of the time we are successful at diverting to outpatient or voluntary inpatient services. So, okay. So that's just a very brief snapshot of our current crisis system. in Thurston and Mason counties. I'll now talk about 988. So some of you may have already noticed that 988 is getting some national press. It is a national act established in 2020. And that really was an attempt on the federal level to make a new behavioral health suicide prevention line that's easy to remember, easy to reach wherever you are in the US. You text or call 988, you will get a behavioral health crisis response, at least by phone. And that's how it is now. And then in 2021, the legislature passed House Bill 1477, and they decided to take it a step further. So they are not just going to have 988 be a suicide prevention line. It is now intended to be a fully enhanced behavioral health crisis response, and eventually it will be the primary hub for how all crisis is delivered in Washington state. That's the ultimate goal. To get there, that bill also established the CRIS committee, or Crisis Response Improvement Strategy and Steering Committee. These committees help design how this is going to be implemented. I was a part of some of the subcommittees for some of that implementation, and then one of our crisis service manager, Jessica Shook, was a member of that CRIS committee as well. So we've been really trying to be a part of how this will be rolled out. There's a lot in there. So moving to the next slide, some quick fast facts. 988 exists now. It's been live since July of 2022 in this version as 988. It's a free, confidential number that is available 24/7. It is, you can text and chat on there, which is unique. The regional crisis lines cannot do that, so 988 is very good for that kind of function. In Washington, we are also we're also unique in that we have a Native and Strong Lifeline, which is specific for Native American population, and we're the first in the U.S. to have that in place. So that's also very good. Next slide. Oh, this one probably should have come before. So there are 3 crisis 988 call centers, or 988 hubs, as they call them, separated into regions. Volunteers of America of Western Washington is the hub that covers our region. They're in yellow. Then we've got Frontier that covers Spokane and Northeast Washington. And then finally, King County gets Crisis Connections. So if you call 988 and you're from Thurston County, you will be connected to somebody from Volunteers of America. There is a caveat, though, in that right now, the 988 line is based off of area code. So if you live in Thurston County, but you have a phone from Spokane and you call 988, you might be connected to the Spokane 988 line. Or conversely, if you live in Thurston County, but you have your phone from Colorado, if you call, you might be routed to Colorado. So that's something they need to work on, and they are working on that. They're very aware of that issue. But for the most part, if you call 988 and you live in Thurston County, you're going to get connected to somebody from VOA. Next.
Yeah. Go ahead. Board member.
Oh, go ahead, sure.
Just really quick, just on that, I mean, if you're connected, right, kind of what you mentioned, someone's from Spokane and they call and they get connected. I mean, is there a way to transfer, like how?
Yes, the regional, all 3 lines, Volunteers of America, Frontier, and Crisis, are connected so that they should transfer over if they're available to do that. Sometimes that's not always best practice, because if you're talking to somebody and you don't realize that they're in Spokane, you might not know that until later. And so then it becomes, well, do I want to transfer this person to another caller and have them tell their story again? We don't want to do that. We want to try and connect to resources as fast as possible, as much as possible. So it just kind of depends, for sure. But hopefully they'll get that worked out soon. I know that there's a plan for that. I'm just not aware of all the details that they have for that. Funding for 988. Oh, back. Okay. Oh, there. Oh, a couple more. One more. It's okay. I'm on it's the funding slide.
10, number 10.
10. There you go. So how does 988 paid for? Well, it's there is a small amount of federal money that's coming in, but mostly this is paid for by a phone fee. So the telecommunications folks the Verizons and folks are the ones that are helping to fund this, and the revenue is listed there. Most of the funding is going to go towards operating expenses for the phone lines, but at least 10% of it, if not more, will go to some of the more enhancements for the crisis teams that I'll talk about here in a second. So you can see the call center expenses are listed there as well. And then, of course, the funding for the tribal line, the native and strong line is there as well. Okay, next. Okay, so I just wanted to give, this is a snapshot of pretty recent data between 988 and Thurston and Mason and the regional crisis line that I mentioned that OHRS runs. So 988 has, as I said, went live in July, but it has not really been marketed. So the call volumes are pretty low. You can see, 237 calls in February from Thurston. So it's hovering right around 200 calls over the last, or the first 4 months of this year. They transferred a very limited number of calls, 10 and 12, 8 and 4, to the OHRS regional crisis line. That means those are the folks that may have needed more than just a phone response. They needed a mobile crisis outreach or DCR. But it seems to me that, judging by these numbers, most of the calls they're getting, they're able to resolve over the phone. Conversely, the regional crisis line that OHRS answers is still very much the primary method that folks in our region use that are in need of a crisis response. Anywhere from 2,500 to 3,000 calls per month are answered 24/7 by our OHRS mobile crisis team members. So the phone never stops ringing in the office. So we think, as 988 gets more marketing, we might see those numbers start to switch. And then it'll really be about coordination between the OHRS crisis system and the CCS crisis system and how 988 will interact together. So.
These call answer times are incredible.
Yes, we worked really hard on that, on the call answer time. So it's part of the contract with healthcare authorities. We need to have an answer within 30 seconds, I believe, and it has to be live answer. It cannot go to voicemail, cannot be press a button to get to the next step. It has to be, got to answer quickly. So.
What happened in February, Joe? 2 seconds?
I know.
We slipped there.
We slipped there for sure. Okay, so the next steps for 988, next one. Okay, so this is largely from the bill. This slide really just talks about the qualifications for the 988 hubs. They got to be highly trained. They have to know how to collaborate with veterans crisis lines, know how to do follow-up and outreach to callers. It's just really about, it's setting some of the bar for who these 988 call takers need to be. The real important pieces are on the next slide, which is slide 13. And so an exciting thing that this legislation is doing will be creating a bed registry, which 988 will have access to. So this doesn't exist now, hasn't ever existed in Washington State, to my knowledge. I think there have been attempts at that, but for the first time, HCA is directed, I think working with DOH, to establish a platform that will allow for 988 to have real-time knowledge of available beds in the state. That's crisis stabilization beds, psychiatric inpatient, substance use disorder, withdrawal management, any type of behavioral health bed. This platform is supposed to know in real time what the access looks like. And I can tell you just from hearing the folks on the crisis line and talking to our DCRs, that's a huge challenge right now. It's just calling and trying to just find a bed for those that need it. That is a real difficult part of their work and takes a lot of their time, for sure. So that will be really exciting when that gets into place. And then the next slide, the final phase of 988 is really being able to coordinate the entire crisis system. That's deploying the crisis teams, obviously tracking the beds, helping to deploy the co-responder teams, the DCRs, any crisis partners that might be working with fire, and then also tracking the response through GPS. I think that's the ultimate goal, is having GPS locations on all of our mobile crisis teams, co-responders, and being able to deploy them very much like a first responder system. I think that's the ultimate goal for the state. We're certainly excited for that. And I know we've got a ways to get there, and then finally, we'll be tracking the outcomes and follow-ups, setting up next day appointments for those that might need it, and so on and so forth. So I was just staying on this slide. Prior to this meeting, I just had a meeting with the healthcare authority about the mobile rapid response crisis teams. That's that first bullet in there. And so this is a new a new component that was expanded on in House Bill 1134 out of this just last session that is going to set an endorsement for crisis teams to respond within 30 minutes. It'll mean that they'll have an enhanced fund source. They will also do patient transports, and 30 minutes, sorry, is for urban counties, I think it's 40 minutes for suburban. And then in rural and frontier counties, the goal is deploying within 15 minutes, I believe. But in any case, I mentioned before, we respond to 96% of our mobile crisis outreaches within 24 hours, try and get there faster than that. This new endorsement, this new money will help for a faster response and a move towards more of a first responder system. And I think that's it for that slide. And then finally, the timeline. So the timeline, the CRIS committee has to complete the report by January of 24. The call center hubs have to be ready to go with most of the implementation pieces I talked about by next July, which honestly seems a little bit ambitious given where we are with some of the hubs. And then this whole thing is supposed to be in place by July of 2027. I can say that I'm on at least monthly calls with the Healthcare Authority and DOH and other partners on just how to move this along. So there's a lot of work. There's a lot of pieces that still need to be figured out with funding, with the platform on with a lot of how we're going to get electronic health records to talk to each other. And there's just a lot of behind the scenes things that need to work out. And then most importantly is the workforce. So I'm hopeful that some of that funding will go towards helping the workforce. We've been fortunate in this region with CCS and OHRS to employ peers and train them to be an integral part of our crisis response. That has not been the case statewide. I know there's going to be a big push for that, so we're hoping we can help any way we can. But all in all, I'd say as somebody who's been in behavioral health for the last 20 years, I've never seen this much investment in certainly the front end crisis response. This definitely didn't exist 5 years ago or even 3 years ago. So it's good to see that we're moving in the right direction in terms of providing that much needed response in this state. With that, I'm happy to take any questions.
Board Member Edwards.
Is there a mechanism when you say you can follow up with those phone interventions that you've done that you said the majority of those were successful? Is there some mechanism that verifies that?
So with most of the calls that come into either OHRS or CCS, there is follow-up, even if it's resolved that day or within that 15-20 minute conversation. Usually it will be, can we check in with you tomorrow or the next day? And then they'll document that in the health record just to ensure that person did connect with their medical director appointment or with their behavioral health provider. And if they didn't, then it can be, oh, well, how can we help to get you to the next step? So we do try and do that continuity and warm handoff for sure.
Thank you.
I'm curious, I think you're already doing this because you're working with the sheriff's office and with the local police departments, but the connection between this new network of resources that you're building for mental and behavioral health, how it connects to our emergency management planning in the county.
That's a great question. I know that one of the tasks for DOH and the Healthcare Authority is how they're implementing the 911 system and how 988 will actually work with those folks. I think that there's talk of having 988 providers embedded within 911 because there is that triaging piece. As I mentioned before, the co-responder teams, most of those dispatches are not done through the regional crisis line or through 988. They're done through 911. So there is a lot of work that still needs to be done there. People will still call 911 if there's an emergency. So, and as I said, as of now, the crisis system is not a first responder system. So likely it'll still be law enforcement that'll get some of those calls. I think there are plans that DOH and the Healthcare Authority have with how they're going to make that connection, but it's still very much in the works. And it'll be regional too. It'll be regional for sure.
Yeah, because I mean, the success factor of, 8 out of 10 calls not ending up needing a law enforcement response is amazing.
Yeah, that's
Not only because of the outcomes for the people making the call, but also because, our emergency response resources are stretched thin already. And so that means that police officers can be responding to something else. So I'm guessing, like, our mobile outreach team in Lacey has, I think, 2 clinicians and two other
Two peers,
folks
yeah.
working, peer specialists. Do we hit capacity with those mobile outreach teams regularly?
No, there's definitely need for more, and I think we've heard from both Chief Almada and also Thurston County Sheriff about can we get more teams? The challenge is workforce, of course, and then funding too. Although those are done in partnership, we still have to find funding on the federal and state side too.
Thank you.
But right now, all of those teams are functioning 7 days a week, at least 10 hours a day. So, it's
Yeah, and I was just gonna say the impact, our program was implemented before the pandemic. And during the pandemic, when all the teens were suicidal, having them embedded in the clinic and be able to call a crisis team with, who will get there within 1 to 2 hours and either meet them at their house or in our clinic, I think saved some lives, pretty sure. And certainly helped us be, like, we already were stressed and burdened, like it relieved that level of worry and that we knew they got care and that they were in good hands. So it's been life-changing.
Joe, you mentioned the 10 regions, and you described the regional crisis line for our region, right?
yes.
Is there any other region that looks like us? Are they all the same?
Oh, that's a great question. No, our region and the Great Rivers region, which is Lewis, Pacific, Grays Harbor, Cowlitz, and Wahkiakum counties, we're actually the only two regions that don't contract with our 988 line to also be the regional crisis line. So in every other region, it is the 988 line is also the regional crisis line. They have different staff, and I really don't know how it works, to be honest. They kind of cross-pollinate a little bit. But in our region, we have not done that, and in Great Rivers, we have not done that. And primarily because our regional crisis line is working well, and our model of having the same folks answer the phone, be the ones to respond, it just really works well, again, with continuity of care. So to the degree that we can continue to do that, we want to still do that for sure.
And if the state follows its timeline and dedicates all these resources and gets all this working, and by 2027, will there be no more need for our regional crisis line, or?
That's a great question, and I don't think we have that answered yet. I think I have a meeting next week to talk about how that transition is going to happen. I think in a perfect world, 988, whether that's done by whoever that's done by, will integrate with our regional crisis line in that 988 will be able to handle the calls that don't need a crisis response, a mobile outreach or DCR, and will be able to triage really effectively those that do need a call. And then that will go to the RCL or just OHRS or CCS directly, and I think that's the ultimate goal. But as for the regional crisis line, how that will be contracted, I don't think even the Healthcare Authority knows quite yet, or DOH, how they're going to interplay together. There's still work to be done there for sure.
Okay, excellent. Thank you, Joe.
Thank you.
Good job, Joe.
All right. Next up is item 6A, setting a public hearing potentially regarding sanitary code amendments to renew designation of Nisqually Watershed Protection Area as a marine recovery area and area of special concern. Jane Mountjoy-Venning from Senior Environmental Health Specialist from Public Health and Social Services to walk us through this.
Okay, good afternoon. My name is Jane Mountjoy-Venning with Thurston County Environmental Health, and we're coming today to ask you to set a public hearing to hear about public input about the Nisqually Shellfish Protection District, also known as the Marine Recovery Area, and continuing that and having some changes to Article 4 of the Sanitary Code in order to make that happen. So a little background, we had come to you earlier to talk about the program. It was set up over 10 years ago to protect and improve water quality in Nisqually Reach in order to protect shellfish beds and make the water clean enough to do anything else in too. It has been successful. At this point, all of the marine stations that the State Department of Health monitors in Nisqually Reach are meeting the standards. There's still some concern about some of the freshwater inputs that they haven't removed all the red zones yet. But it's been successful. We've reopened about over 100 acres of shellfish growing areas in the Squally Reach. And the Shellfish District Advisory Committee definitely recommends, as does the Health Department, recommend that we continue the program. And to do so takes both Board of County Commissioner action and Board of Health action. So the Board of County Commissioners get to approve the work plan or make suggestions and changes to the work plan. And the work plan's combined Henderson and the Squally, because it's a lot of the same actions, no matter where you are. And the Board of County Commissioners gets to set the rates and charges to then fund implementation of the work plan. The Board of Health has the responsibility to declare the geographic area, which is the same one, we're not changing that, an area of special concern and a marine recovery area, which is what's required by law. And then to make amendments to the sanitary code, in particular Article 4, which deals with sewage. So that's what we're asking you to do, is to set the public hearing, hear the input, and then either at your September or your October meeting to make that decision. Any
Okay,
questions?
so pretty limited situation today to set the
Today's
public
just setting
hearing.
a public hearing, yeah.
May I ask, it might be something the board would be curious to know. You've used these two terms, marine recovery area and area of special concern. Are they different? Are they the same? Are we designating them as both? Why would we do that? What's the
Right.
difference?
You're designating them as both. I would say an area of special concern is maybe broader, and a marine recovery area is one type of area of special concern. We have in our code the ability to say, for example, this has not been done, but say Summit Lake is a drinking water lake. At some point, you may wish to declare that an area of special concern. So it wouldn't be a marine recovery area because it's fresh water. But you could put that designation on, declare a boundary, and enact special requirements in that area. Again, that hasn't happened. I'm not suggesting that right now, but
But because we're
just
doing
saying.
that, we need to do them both because they're,
It's kind of, they
go
they
together.
put on. And then the marine recovery area is particular to the shellfish protection districts. And
Board Member Edwards.
Was that done for the Evergreen Valley because Olympia was getting water?
McAllister
McAllister
Springs, I think it was declared a special area, the McAllister Springs Wellhead Protection Area. Yeah.
Now, is this all encompassing then? And the only reason I'm asking that particular question is McAllister Springs was put in place because Olympia was getting their water out of that aquifer.
Mhm.
But now they've quit drawing water out of that aquifer.
No, they're still same aquifer, just further up gradient in it. But this,
I thought it was down way farther,
Hmm?
way deeper than it was, like a whole different aquifer.
it's on the other side of the railroad track. So if there's a railroad spill that was gonna take out McAllister Springs, it would still be protected because the water's flowing that way. But
Okay.
these rules are gonna be particular to the Nisqually, well, a little bit of it will apply otherwise, but the ordinance revisor is more towards the shellfish protection districts or marine recovery areas. Kind of use them interchangeably.
Is there any chance you could make sure you have that information? Because I've been asked that question
Sure.
about McAllister Springs for that hearing. I mean, maybe a citizen will bring it up, maybe not, I don't know, but I think it's worth knowing because it was sold to the public when it was put in 10 years ago or whatever it was, that Olympia was getting their water from that aquifer, and then something happened, and I don't know what happened. You're mentioning a well site was moved, but I was under the impression that the aquifer was a change from one to the other.
Okay, I will check on that.
Okay, thank you.
Is there a legal, like, by us declaring something a area of special concern / marine recovery area, does that then open up options? I mean, why are we doing that? Does
Right,
it open up legal options for charging fees for
Right, it
programming?
opens up the options to then require, in this case, additional regulations around their septic systems. So that's some of the language that requires currently until December 31st, because of the designation as a marine recovery area, all of the septic systems in the designated area need to have a renewable operational certificate for their septic system, which requires them to have it inspected every 3 or 1 year, depending on their system, and turn those reports into the health department.
If there's no special concern, you're not allowed to require an operation.
You could decide to, but this makes it, this was the mechanism that was chosen back in the day.
Mr. Chair, can I make a motion?
Yes. Let's wait, let's see, any questions? Good? Okay, I'm ready for motion.
I move that we approve setting a public hearing for Tuesday, September 12th, 2023 at 5:30 PM or as soon thereafter the matter may be heard at 3000 Pacific Avenue Southeast, room 110, to receive testimony on the proposed ordinance to amend the sanitary code, renewing the designation of the Nisqually Watershed Protection Area as a marine recovery area and area of special concern, add a requirement to report minor on-site sewage system repairs in marine recovery areas and areas of special concern, revise the requirements for inspections of on-site sewage systems and other technical corrections.
Second.
It's quite a motion.
Motion and a second regarding setting a public hearing for Tuesday, September 12th at 5:30, which would be during our normal Board of Health meeting, about an hour in, looking at administrators. Yes?
Yeah, you will stop your Board of Health meeting,
Yeah.
conduct a public hearing.
Yeah, I don't have my calendar in front of me, but that sounds right. Okay, good. And the board actions on the 5th, so that's the sequence that needs to occur. Any discussion about this motion? Call for the vote. All in favor, say aye.
Aye.
Any opposed? Motion carries. Thank you, Jane. Okay. Item 7 is our health officer's report. Come on down, Dr. Abdulmalik. Good to see you.
Good evening, Board of Health. I wanted to start out a little bit talking about COVID. We are starting to see our numbers uptick a little bit. So our current numbers based on the DOH dashboard for the reporting period ending July 24th are 27.8 cases per 100,000 over the preceding 7 days. And 54.6 cases per 100,000 population over the preceding 14 days. This is really only CLIA waived and CLIA approved tests. So some of the other measures that we're looking at include wastewater surveillance. So the lot water system actually tracks SARS-CoV-2, the virus that causes COVID-19 levels in the water. And so we're starting to see a slight uptick in our wastewater surveillance as well. So that kind of helps us get a better sense of where we're at as a community. Our hospitalizations of folks who've tested positive for COVID-19 remain low, but they're a little bit higher than they were in the middle of July. So we're at about 2.1 hospitalizations per 100,000 over the 7 days leading up to July 29th. So that would be the last CDC, the most up-to-date CDC reporting period for hospitalizations. You know, we are, so the currently circulating variants are all derivatives of the Omicron variant. And we're not seeing an uptick, we're not seeing a significant uptick in deaths as of yet, but we're watching trends, transmission trends, hospitalization trends pretty closely. We are also anticipating that an updated COVID-19 vaccine will be available in the fall. We're still, waiting on, specific timing, will depend on the approval timeline and all of those pieces. But we are definitely preparing for that. Thinking ahead to the viral respiratory season, some of the big changes since we last spoke that I wanted to highlight is that, so when we were looking at the season last year, we had a lot of trepidation. We continue to track the Southern Hemisphere pretty closely, but we ended up in a situation where we had COVID-19 circulating, influenza circulating, and RSV circulating. So this year, we're anticipating an updated COVID-19 vaccine being available, the updated flu vaccine, and then for the first time, there are options for folks at high risk with regard to an RSV vaccine. So folks over 60 may take an RSV vaccine if they, with the recommendation that they talk to their healthcare provider about the specific risks and benefits. And there's an immunization, so a long-acting antibody that's been approved for infants under age 8 months, and then for some older babies as well, depending on their risk of severe disease. So this is, the timing of how all of this will get rolled out. We're still kind of watching the operations side of that. But it's definitely good news that we're moving in a positive direction with regard to protecting folks who are vulnerable from viral respiratory illnesses. I wanted to
We have
also,
COVID questions, if we could
oh yeah,
stop you. Commissioner Maria.
Okay, I wanted to talk about the flooster. The flu and COVID booster is what
Booster.
booster. Uh, and just it coming out in the fall, and you're saying that you're preparing for it, and so I'm just wondering what preparations are taking place for that becoming available in the fall. I've heard kind of like a lot of rumblings, especially as the trends for COVID have been going up and people are wanting to access that. So is it going to be at pharmacies, or is it something that public health is going to be initiating clinics again? What does that look like?
yeah, no, really, really good question. So with the new COVID-19 booster, it does represent the commercialization of the COVID-19 vaccine, so it should be available at pharmacies through healthcare providers. We are looking at our capacity as a team to support, just as we, pre-pandemic, we've placed a priority on filling gaps, and supporting folks who have limited access. So thinking about folks without insurance or insurance that doesn't cover vaccination as well. So in terms of, so we are in the planning process to see what clinics we may be able to offer in the fall to kind of support this effort. We're also very fortunate that we have community partners that are also interested in supporting the work of helping our community get vaccinated.
And it's just one more follow-up. I know that from the Board of County Commissioners, we approved an amendment specifically for COVID funding, and I'm just wondering, is that, how kind of that plays just into the role of the future and support?
So I'm gonna have to defer that question. So the health officer doesn't, that falls outside of my scope. I definitely defer to Erin, our division director.
Hello, Erin Berklid, Division Director for Disease Control and Prevention. So we're in the planning stages to see about what our staff can do to help do vaccines throughout the fall so far. And then we have put requests into the upcoming biennium budget to hopefully have additional staff supporting vaccination efforts through the COVID funding that will be ongoing over the next 2 to 3 years. So for the fall, we're hoping to do 2 clinics a week if possible to reach underinsured and those with no insurance. And we're in those planning stages to try and finalize them. But that's where we're at right now.
Can I ask one more question?
Yes, ma'am.
So my next question is in regards to COVID tests and the availability of them. And so I received something in the mail that said, you can claim your free test from your insurance, but all the pharmacies right now are ran out. Like there's really no, the availability of it is not what it used to be. And so I'm wondering, is that kind of the trend that we're seeing everywhere, or?
We are hearing a lot of reports of test shortages. I know that our COVID team has been distributing tests at various locations in our community. Right now, I believe we've distributed tests to some of our libraries, the Timberland Regional Libraries, so folks can access them, and we're always, if they're willing, community partners where folks can, readily and easily access tests. We're also looking into other options as well to increase access.
Can I ask one more? I promise this will be my last one in relation to COVID. And just in the same line of COVID test, one of the things, right, that I've been hearing just as the numbers have been increasing, that expired tests will usually give you like a false negative, and so I'm wondering if that's what you're hearing, it's maybe people shouldn't, if their tests have been sitting in their cupboards for a long time, that maybe they should go and seek new ones. Is that the recommendation, or?
So we're hearing a lot of different things
Yeah.
in the community. I think so. The Washington State Department of Health has guidance on using expired tests, and the thought is that if the control is still good on the test, then then you can go ahead and use the test even past the expiration date. If there's a question, definitely feel free to buy or acquire a new test. This guidance was developed during past testing shortages, and has been at a population level has been fairly reliable, although we hear stories of false negatives and false positives as occur with any test.
Now you made me think of a question. Does the virus, because there's a new variant, it starts with an E, I can't remember, E something.
EG.5.
At what point does the virus mutate out of the being able to be captured by the test? I mean, how broad is the test that we've been using in the past?
So what I will say is that I believe it is the FDA is making sure that makes sure that the tests are still accurate and reliable, the ones that have been approved. So there's ongoing checks. So as far as a specific answer, I'm not
We
sure.
should hear about it, though, if it becomes a point where there's a new variant and the test is not going to capture that, and we need to know that, so we don't keep buying and taking tests that aren't telling us what we want to know.
Yes, and in the past, when tests have not been reliable, that information has been shared with us as a health department, and we've been able to share that information out.
Go on to your next topic,
I
Dr.
have
Ray.
a
Oh, no, we
question
got
too.
one other one.
So sorry. Do you expect to put out school-specific, or Thurston County school-specific guidance this fall as school starts? Or are you going to rely on Department of Health's update?
So this morning, we actually issued a letter to superintendents and heads of schools. So we, in Thurston County, we do fall into alignment with the Washington State Department of Health guidelines for COVID-19 mitigation in schools. They're probably the only place where we have a county-specific guideline is for the instance where people aren't able to track COVID-19 test results for a population or for a core group, whether that's an extracurricular group, a classroom. In that setting, if there's 20% absenteeism over 3 consecutive days, the guidance is to suspect a COVID-19 outbreak and get everyone tested in that group unless there's an alternate explanation that's not COVID related. But other than that, we anticipate following the Washington State Department of Health guidance and further anticipate sundowning our school's communication flow chart and utilizing the State Department of Health symptom tree.
Thank you. Could I get a copy of that letter for school nurses and health centers, please?
Definitely.
Thanks.
I thought we were gonna hear how many fentanyl deaths
Still on COVID.
Oh, you're switching. I thought you were done and gonna go away. I
Continue
wasn't
with your
gonna let you off
report.
the hook that easy. Thank you.
No, not a problem.
Okay, sorry about that, Chair.
No worries.
I just had a couple more things I wanted to mention, and then we'll talk a little bit about opioids. I wanted to mention briefly the listeria outbreak that you may have heard about in the news that included 5 listeria cases, 4 in Pierce County residents and 1 in a Thurston County resident. That has led to a total of 3 deaths. These were in older adults. So listeria is a bacteria. It's most often, so folks get it most often by eating contaminated foods. So thinking about, raw dairy products that are unpasteurized, deli meats, cut melon, things of that nature. We continue, so when they looked at the genetic signature of the listeria that was isolated, it looked like there may be a common source, so that investigation is ongoing, and our team is working with the Pierce County team and the Department of Health team on that work. And there haven't since the time of that release, which was in the middle of, or 2.5 weeks ago, we haven't seen any additional Thurston County cases, but we remain on alert, as it were. I also just wanted to mention that we do have some lake advisories in effect, as we do every summer, currently for Pattison Lake and Black Lake. So folks can come to our website and see what the specific lake advisories are. And now, without further ado, I'd like to talk a little bit about our overdose deaths. This will be a brief discussion and update, and I know that a request was made for Katie Strozik, who leads our opioid task force, to present in more detail at a future board meeting. So just wanted to share our numbers on overdose deaths through July 31st of this year, so from January 1st to July 31st. So the confirmed drug overdose deaths that we've tracked are 32, and this is any drug, not just opioids. And there have been 25 overdose deaths related to any opioid, and that would include fentanyl, heroin, or any other opioid. So this data is really preliminary and subject to change, because this is looking at data that based on death certificate data that are finalized by medical examiners and coroners, and there can sometimes be it relies on toxicology results, which can take a significant amount of time to finalize. So often we won't get a complete data set until Q3 or Q4 of the following year. So I know these numbers, they're much higher than where we were in the past, but it's still too early to tell. That we suspect that this may be that this is likely an undercount so far, and we'll have more numbers in the future. I did want to share some other information that we have regarding opioid overdoses and the importance of naloxone. So we're able to distribute naloxone at our syringe services program. So as part of the Department of Health program, when we distribute naloxone, we also ask some questions of the folks receiving it. And one of those questions is, have you responded to an overdose? And if you did, was that person successfully reversed? So this is all preliminary, preliminary data from those surveys. So, but I wanted to share them because it really illustrates how important, naloxone access is. So, and this is just a survey of the groups, of the people accessing our certain services program. So in terms of what occurred in 2022, 193 overdoses were reported as folks responding to them, and 183 of those were reported as being successfully reversed. So that's, so we are seeing, we are seeing deaths. And we're seeing that when folks have the tools to prevent overdose deaths, they're using them and it's highly successful. So far in 2023, there have been 125 overdoses reported as folks, the folks who were getting more naloxone reported that they responded to them, with 120 successful reversals that were reported. And so far this year, 1,596 kits have been distributed through our program. So this is, so even though we are seeing, we are seeing deaths, we are also seeing people really stepping in to help when they have the tools and saving a lot of lives. One last thing that I wanted to put on your radar, and then I'll be done, I promise. And that is, I wanted to talk briefly about xylazine. So xylazine is a veterinary sedative that has been added to other drugs, most commonly opioids, and in Washington state, most commonly fentanyl. And the thought is that it extends the high a little bit. So this it acts in a different way than an opioid does. So so naloxone reverses the opioid, but it wouldn't necessarily reverse the xylazine effect just because it works a little differently. However, because they're mixed, I just wanted to emphasize that if you do suspect an overdose, to use naloxone first because xylazine is being used in combination with an opioid. And even if you can, if someone's overdosing and you can reverse a significant amount of what's sedating them, that still saves lives. Even if you can't completely reverse all the sedative effects from the substances that a person may have taken. So that's one reason, thinking about the impacts on folks who are using is one reason to bring it to your attention. The other reason to bring it to folks' attention has to do with that this substance, that xylazine has been associated with wounds that are deep, that involves, soft tissue, involve muscle, they get infected. And so we're starting, providers are starting to see kind of these severe wounds in our community. And so I just wanted to make folks aware that that if you see someone with these sorts of wounds, talk to them about their drug use. Make sure that they know make sure that they know that if they are going to use, how to use safely, and that there are resources available to help them quit and stop using. So those are my big asks. We're going to be watching this trend carefully as we do a lot of all things opioid related. And with that, I'm open to any additional questions.
On that xylene, is that what it was?
Xylazine.
Xylazine. So if they take a combination and they go down, so somebody's gonna apply so they reverse the effects. So it will reverse the fentanyl effect, but what is the effect that's left on the individual that they should be watching for if it's a combination drug that they took?
Yeah, so xylazine can be sedating, it can lower your blood pressure, lower your heart rate, it can lead to, it can lead to confusion. So So that would be some of the lasting, that would be some of the lasting effects, even after the opioid part of the overdose has been reversed.
Is it just as deadly in the small quantities as fentanyl? Like,
So in general, it hasn't, I haven't heard of cases where it's been taken alone intentionally. It doesn't have, in large quantities, it does have the ability to lower your heart rate, lower your blood pressure, which can lead to death, you know, along with sedation and along with decreased breathing. But it typically doesn't act as quickly or as fentanyl does. It's the challenge here is that because these are illicit substances that aren't regulated, so you know you're not really sure what you're getting, how much, how strong. So it's hard to make some of those determinations.
Did you say we are seeing that use in our community, xylazine?
So we are seeing folks with wounds that people suspect may be related to xylazine exposure.
And you're talking about injection site wounds?
So what's interesting about xylazine is that you can get wounds at the injection site, but you can also get wounds at areas areas that are different from the injection site. You can also get wounds have also been reported in people who've snorted and smoked opioids, yeah, with xylazine in them.
And just for your information, we also have data on naloxone that's administered in schools on a state level, and we can tease it out by county for the last 2 years.
Would be really helpful. I guess one last thing to share is that our syringe services program, so the Washington State Department of Health has xylazine test strips available, and our team is working to get some of those test strips to make those available for folks in our community in case that, you know, just no test is 100%. There's very clear instructions on how to use them and what the test does and doesn't mean, but it's additional information for folks who want to stay safe, who want to be safer. Thank you.
before we adjourn, we would get a brief report from our director is out, but Assistant Director Jen Freiheit's here. Did you have
Sure.
any items you wanted to report to the board?
Sure, thank you, Commissioner and board members. I'm Dr. Jen Freiheit. I'm the Assistant Director sitting in for Director Bain. And I'll just give 4 quick highlights of other things that are going on. Right now, we are again able to accept online birth and death certificate requests through our vital records. This was a 9-month process and we just put out the press release on July 31st and I've already had good uptake. People from other states able to now get in that way. We have a water quality data dashboard that is going to be coming to fruition this fall. We're very excited about. So both an internal and an external dashboard within a few months. Both the Thurston County Affordable Housing Advisory Board and the Treatment Sales Tax Advisory Committee are now reviewing and looking at respective funding requests. So those will come before you very, very shortly. And we are sitting on 23 open positions in PHSS. So we now have currently at this very point, we have a full administrative services team, fully staffed, but as you can imagine, extremely busy with those open positions that we're working heavily on recruiting.
Thank you. Any questions for?
I guess, is there anything about a overdose awareness day on August 31st? Are you familiar with that? Is there anything planned for that or what's up about that?
So yes, we are participating in Overdose Awareness Day on August 31st. I am forgetting the location. I believe it's Heritage Park, and it's from 1 p.m. to 7 p.m. with resources available from 1 to 5 if memory serves. And yes, we will be there.
Okay. Anything for the good of the order before we adjourn tonight's meeting? Thank you very much. We are adjourned.